Good morning or good evening if it's nighttime for you. Welcome to NBME explanations. We last time we left off at question number 41. So 40 questions are done. NBME 22. Let's wait a little bit and then we can get right into it. Let me just finish typing something. So, as usual, keep in mind that NBME is an excellent way to study. Really important to go ahead and get all the correct answers, as well as UWorld style explanations of why the correct answer is correct, why the others are wrong, if possible. And remember that the page numbers I've written here, the first page number is the actual first aid number, whereas the second one is the number for my annotated PDF. So now, as usual, always make sure that you're able to really catch what's happening. Keep practicing, don't stop. If there's any topic that you don't understand, you're always welcome to ask questions during live, or you can email me if you have any questions about any of the equipment I'm using here, or not the equipment, any of the books I'm using here. If you want to purchase the annotated first aid or any of that, I also sell the explanations, and I've done a couple explanation videos already. So if there's another NBME you want explanations for, I might actually have a video for it. Like I've done 18, 20, 23, I think some others. So this is 22. Let's get going now. So number 41. A 37-year-old man comes to the physician for a follow-up exam. He has a 1-year history of hypertension. Despite aggressive pharmacotherapy, his blood pressure has averaged super high. His blood pressure today is also super high. Fundoscopic exam shows multiple flame hemorrhages with severe arteriolar narrowing, so he has end organ damage now. Which of the following disorders of blood vessels is most likely to be caused by this condition, right? So what's most likely to be caused because of the excessive hypertension? And it's a pretty easy question because you look at the answer choices and you can pretty much immediately pick C, hyperplastic arteriolosclerosis, as something that would occur because of hypertension. So I guess the question was really just about, which one of these answer choices is really related to hypertension. So hyperplastic arteriolosclerosis is totally a thing that you see in hypertension. Some of these others might be related to hypertension but are not due to hypertension, right? That's what the question is about. So this patient has chronic absurdly high hypertensive emergency, basically, right? Hypertension causes hyperplastic arteriolosclerosis, also known as the onion skinning. The basal membrane gets injured due to the hypertension, so compensatory addition of smooth muscle occurs concentrically towards the lumen, right? And first aid has that, so let's take a look at it real quick. Right, so that's all your stuff right here, right? So you can see image B over here is showing you the onion skinning and severe hypertension. This is arteriolosclerosis. Monkey bird sclerosis, which is this one over here, is uncommon. It doesn't really have much to do with hypertension either. It's calcification of the internal elastic lamina and media of arteries, leading to vascular stiffening without obstruction, right? Where here you can see there's crazy amounts of obstruction. The hypertension just gets worse, right? In arteriosclerosis, what happens is you have hypertension, it causes injury, you try to fix that injury, and you make more hypertension because fixing the injury involved doing this, right, which narrowed the lumen even more. This is also arteriolosclerosis, but this one is hyaline, right, because the hyaline stuff is related to diabetes. Right, so you have, here is where you're seeing damage due to non-enzymatic glycation. Right, so very important to catch all of that kind of stuff. This image down here is the one showing you the monkey bird sclerosis. So you see how there's no blockade, then the lumen in the middle is okay, but there's calcification and shit in the internal elastic lamina and whatnot. Right, but blood flow is not obstructed, so you don't necessarily see hypertension in there. It's just a different type of sclerosis. Right, and that was also one of the answer choices here, medial arterial calcification. Alright, so that's not too bad. This one case control studies conducted to assess the relationship between exposure to environmental tobacco smoke and sinusitis. The table shows the results of the study. So you have cases, exposure, controls, no exposure. Okay, so it's in the correct format. Remember that the correct format, you always want to have your boxes. Oh, this is yellow. Why is it yellow? So you always want your boxes to be like, plus, minus in that format. If it's not like that, you really, you really can't apply the equations so accurately. So you want to make sure you can rearrange this in that format if necessary. Which of the following is the prevalence of sinusitis in the general population? Right. So they just want the prevalence, which this kind of question really catches people off guard sometimes because we don't really necessarily tend to remember an equation per se for prevalence. But prevalence just means how many people have the disease, right? Compared to incidence, which means how many new people got the disease more recently, if anything. So they have all these numbers, 16, 40, 50, 80, and then this trick answer choice cannot be determined from the data given. Right? Turns out, though, it's not really a trick answer choice. That is the correct answer choice, right? If you felt weird first of all, if you're doing NBME explanation videos, you've probably already taken the NBME, or you're taking an NBME for your actual school soon, so you're reviewing. When you read this question, something should feel off, right? Because you read the question and you see, oh, they want to know the prevalence, but all they gave you was this chart. Now you go back to first aid. Right. Well, you won't be able to go back to first aid during your test, but in your mind, you should be able to go back to first aid. You're going to remember that where you saw that chart, right, which is this page right here, basically, right, you don't see prevalence as one of the things on this page, right? You can, when given this information, you can calculate any of these things, sensitivity, specificity, PPV, NPV, but you cannot calculate prevalence off of this, right? Because this is stuff about prevalence, right? Even here, right? Odds ratio, relative risk, all of these things are things you can calculate, but you cannot calculate prevalence off of that. Prevalence does have an equation, and it's exactly what prevalence is by definition, right? How many people have the disease? Number of existing cases divided by the total number of people, right? That's how many people have the disease, and they didn't really necessarily give you that. They didn't tell you how many people exactly have the disease. Now, there was a way to do this incorrectly. You could think that, okay, exposed to smoke in cases is 20, but the total number of cases is 25, right? 25 people have the case. So you would pick 25 and then add up everything else. And let me see, I think they might even have an answer for that. So 25 and then 150, right? So 25 over 150. So that's like 20%. That's not an answer choice, right? Actually, they don't even have an answer. So they don't have an answer if you actually tried calculating this. I don't see. Oh, yeah, actually, this is it. Yeah, 16%. Yeah, 25 over 150 is 16%. Yeah. So, that's one mistake people can make, right? You could think that total number of people with the case is 25 and total population, which this is not total population, right? Total, I'm going to put it in total of what you think is population is equal to the total number of people in this chart, which is 150. So 25 over 150 is equal to 0.16, right? And that would be wrong, right? Because that is not your total population. That's just the population of this test. Right, that's just not even the population. That's like the sample size of the test, which really doesn't, define prevalence. Prevalence is not defined by a sample size. Prevalence is the actual population of whatever group you picked, right? Maybe a city, maybe a school, whatever you picked. So that's really important to watch out for. Do not fall for that. Right? I'm sure there was another way to get some of these other answer choices too. So you really want to, when you see an answer choice like this cannot be determined, you don't want to take it lightly. Yeah, I'm glad that my videos are helpful. Thank you. So yeah, this is something that was a really good question. I liked it because it kind of gauges um, how well you can understand a topic, right? What your mastery of this topic about statistics is. And remember, previously I was talking about how the list of topics that are in an NBME are much smaller than the list of topics that are in a step one, right? So I've been writing down all the questions we've done so far, right? And these are all the topics that have shown up on NBME 22 as I'm reviewing it. So 41 was arteriosclerosis. I'll add the rest of them as I keep going. But the point is that there are some topics that don't really show up on NBME at all. Like, for example, biochemistry metabolism, extremely rare. Right? Biochem nutrition can be on NBME with metabolism stuff, with urea cycle and knowing enzymes of glycolysis and glycogenolysis. Those are pretty rare. What does possibly show up is like those metabolic diseases, right? Like the lysosomal storage diseases, the glycogen storage diseases, those can show up, but it's also pretty rare. And you should know them anyway. Those are easier to know than to, know all the enzymes and whatnot. So you can definitely know those. Biostats, though, definitely a high yield thing in NBME, right? And a lot of people are preparing just for NBME because their school requires it. You want to be able to master that 60 to 70% of first aid that is NBME, right? Then there's a 30% of first aid that's actually for step one. You're never going to see a cardiovascular pressure volume loop on NBME. You're not going to see a respiratory curve on NBME. Stuff like that. Those things don't show up, so you don't really want to waste too much time studying those if you're preparing explicitly for NBME. This one says, a 52-year-old man with metastatic oat cell carcinoma begins to receive hospice care. Treatment with narcotic medication is initiated for severe bone pain. Which of the following actions by the physician regarding this treatment is most appropriate? Right? So basically what they're telling you in the question, you need to understand that before you even look at the answer choices. What they're telling you in this question is this guy is going to die, right? Because he has metastatic oat cell carcinoma, and now he's getting hospice care, which basically means that you're giving him as much comfort as you can before he dies. Right? You want to take away all the pain, all the discomfort, any other issues he might have, and keep him in peace, I guess, until he passes away. So what would be, which of the following actions by the physician is most appropriate for someone who's about to die? Okay, and I'll tell you why that's important. So let's take a look. A, begin with minimal amounts of pain medication to monitor any adverse effects. Again, he's about to die, right? This is where this becomes important. He's about to die. You don't care about adverse effects, right? We're not going to hold back pain medication from this man who's in pain because of his cancer just because we think he might become constipated, nor do we care about him becoming addicted, which is the other answer choice. Right? Carefully monitor the administration of this pain medication to avoid patient addiction. We don't care if he gets addicted. It's okay. It's right because he's about to die. Right? All we care about is if he needs a shit ton of opioid, we will give it to him. What we need to care about is not to kill him. Right? We don't want to kill him, which means that we will make sure we don't give him so much opioid that he ends up having respiratory depression and then dies. Right, so the next one, ensure that the patient receives enough medication to control his pain. Perfect, right? Enough to control his pain, and then the next level above that would be more to kill him, right? Don't kill him. So just give him enough, right? Then so C was the correct answer here. The next one, make sure that the patient does not have direct access to the pain medication to avoid an intentional overdose. Again, this is something that's really weird, right? And it feels a little weird to say it. It feels a little maybe even harder to accept it. But the truth of the matter is, if he decides to intentionally overdose and kill himself, that's something that he would decide to do, and you really can't, safeguard him from doing it. If he wants to do it, he will do it, right? You have to give him as much as he needs, and if he decides to do an intentional overdose and kill himself, hopefully he won't do it. But if he does it, he'll do it. You don't withhold opioids from a patient in hospice care who has end stage disease and is going to die just because you think that they're going to overdose, right? And then the next one, regularly assess the patient for respiratory depression due to the pain medication. This was a tricky answer choice, okay? And this is also quote unquote correct. It's also correct, but C is the better answer choice, right? Our priority is not assessing him for respiratory depression. Our priority is to make sure he has enough to control his pain, right? He's in hospice care. He better have no pain. That's how this works. And hospice care, also remember, hospice care is extremely expensive. Okay, it's very pricey stuff. So if a patient in hospice care is in pain, whew, you're paying for nothing at that point, you know. So you don't want that kind of stuff to happen. All right, so that's basically it for that. Next one. 44. A healthy 25-year-old man eats a meal consisting of 60% carbs, 30% fat, and 10% protein. His serum insulin concentration is increased after the meal. Which of the following is the most likely mechanism of pancreatic secretion of insulin in this man? So this man is not a special man, so this is just a question about any other man. What is the most likely mechanism of pancreatic secretion of insulin in any man? And you look at the answer choices: diffusion of insulin across the plasma membrane by an increase in intracellular bicarb concentration. Again, if you don't remember the mechanism of action of how insulin is released, this is pretty much the second question on this topic. They had another question earlier in yesterday's video from diabetic ketoacidosis, which is also directly related to insulin. Without insulin, potassium won't be going into cells, right? And you end up having issues regarding very messed up serum potassium levels, right? So here, when they mention bicarb, that should ring a bell for, well, it shouldn't ring a bell actually, right? Because bicarb has nothing to do with insulin going into cells, so that's wrong. Diffusion of insulin across the plasma membrane through a glucose transporter. Insulin doesn't go through a glucose transporter. Glucose goes through a glucose transporter, so B is wrong. Diffusion of insulin across the plasma membrane through a protein transporter. Trick answer choice, but the fact of the matter is, if insulin needed a protein transporter, you should be able to tell me what the protein transporter is, because you've been studying for a while, right? And no protein transporter comes to your mind, so C is wrong. The enzymatic hydrolysis of the plasma membrane, that sounds pretty bad. That's like, why would you hydrolyze plasma membrane? Then you're pretty much going to kill the cell. And the E, fusion of an intracellular vesicle with the plasma membrane. And maybe, just when you read that answer choice, it comes to your mind and you remember that image of that actual fusion occurring. All right, so let's go take a look at that. 349, that was the correct answer, E. 349, or where did I type? Like that, 349. Or 324 for the actual first date. So you can see here on this page, the first thing they talk about in endocrine physio is insulin. Very high yield topic. You need to know it inside out. And you see some transporters and stuff, but look at how insulin works. You see how insulin is exocytosed? It comes from inside the cell and it comes out, right? Which means if you're leaving the cell, always remember, one of the main ways packaged things leave a cell is just by fusion, right? Because leaving is an easy thing. Leaving, just remember, just like leaving a country, like leaving America is very easy. Coming into it, not so much, right? So leaving the cell is no big deal. You just fuse with the membrane and you leave. And the cell gets to keep the membrane too. You see that circular part here came from here. It gets to keep it. So really nothing was lost. You just release insulin. And that's how that works. And remember how it started, right? For it to start, you have to first get ATP, right, to close the potassium channels. So potassium is no longer coming out. All the potassium is stuck intracellularly, which is why in DKA, serum potassium levels, right, because they don't have any insulin, serum potassium levels outside will be low, right? And because potassium is, no longer coming out, and that often leads to other issues. And patients present and on their labs, you're going to see potassium is well below 3.5 in DKA. That's very important to remember that. Very straightforward question, but definitely, a lot of people can easily get confused by reading such a thing because they get intimidated, right? That's kind of what NBME does. They'll pick something very easy and present it in a way that makes it look like, oh, this is supposed to be a hard question. Are you going to get it right? It's not a hard question. They're just asking how is insulin released. That's not a hard question. A hard question would be, giving you heart sounds and stuff like that, and then really trying to get you to figure out exactly where blood is flowing. something like that, cardiovascular, respiratory, hardcore endocrine questions regarding congenital adrenal hyperplasia. Those would be hard questions. This was a very easy question regarding how is insulin released. Okay, and insulin is being released. Releasing things never requires, not never, but generally speaking, doesn't really require a transporter per se. You just release it. Okay. This one was a really nice image. Right? They did a really good job picking on this. What I often call it, it looks like a cotton swab, the ones that you use to clean your ear. Right? So this is actually a ferruginous body, and anytime you see an image like this, you need to think of that immediately. Right? It's in for a state 2. Right? This is something that you do need to know, all of your pneumoconioses. Right? It's a very easy way to memorize them. Asbestos is this one right here, asbestosis. Shipbuilders, plumbers, roofing, insulation. Asbestos is asbestos, right? It goes to the base of the lung, lower lobe, but it comes from the roof. Okay. Hold on a minute, so I'll get back to that. Berliosis, right? Aerospace manufacturing, berry grains, so it looks like granulomas. Remember that berliosis is going to have a non-caseating granuloma. So always remember berry grains, right, for berliosis, and the grains is for granulomas, and this is for aerospace, upper lobe. They're all upper lobe except, the only one that really affects the base or the lower lobe is just asbestos. Coal, right, is from coal miners. It causes Kaplan syndrome. Kaplan syndrome is the one that has rheumatoid arthritis with it too. And silicosis, this one is all sandblasting, silica, metal casting, eggshell calcifications. Right, very important to remember those things. So one of the cool things in asbestos was the ferruginous bodies, right? What they show you here, this one right here, yeah. So it looks like a cotton swab, the ones you use to clean your ear, right? So that's what they're showing you here, and they gave you enough information here too. They mentioned that he worked at a shipyard, right? And then they gave you a shit ton of answer choices because it didn't matter how many answer choices you had. As soon as you know this is, asbestosis, you should be able to pick alveolar macrophages and be done. And you do need to know what the others do, and these other ones have very simple functions, so none of them would make sense because they want to know what caused the fibrosis. The fibrosis is most likely initiated by interaction of these structures, the ferruginous bodies, with which of the following cell types? With macrophages. That's it. DKA, right? Let me check that real quick. Oh, I mistyped it. Keto S. Okay. Yeah, so potassium. You see, you end up having total body potassium depletion. Okay, for two reasons. One, because without the insulin, you don't release potassium from inside cells. Right? Potassium was coming out, and what's supposed to happen is you're going to close those channels. It's not going to come out. Right? And you can see insulin required, right? These people don't have insulin, so they get diabetic ketoacidosis, and you lose your potassium in urine. Okay, so they tell you when you have to treat these people, you have to give them potassium. Right? Total body potassium is lost. Extracellular potassium can remain normal or increased because of the potassium hydrogen exchanger activity and lack of insulin, since insulin is supposed to promote cellular uptake of potassium. Right, so in case I said it incorrectly, it's here now. I might have said it incorrectly. Let's take a look at it one more time with the insulin stuff. But the main thing is that these people lose potassium because of the osmotic diuresis. Right, so diabetic ketoacidosis patients, when you treat them, you give them potassium, even though their outside potassium levels might be normal, right? Because you need to fix the intracellular storages. And then let's look at insulin again, because I forgot where I don't know what I said when I said it here. So with insulin, right, normally when glucose comes in, you have more ATP, and that closes this, and now you cannot, you're not going to be releasing any potassium. And when that happens, all the potassium gets stuck inside, you get the depolarization of the calcium channel, a lot of calcium comes in, and then you release insulin, right? So you're going to have potassium in here, but outside, you're not really going to have much potassium, okay? And that's the part that I was talking about. It's a different thing, completely different scenarios, but they're heavily related to each other because insulin and diabetic ketoacidosis are pretty much the same, same topic, diabetic ketoacidosis, is due to lack of insulin. Okay, so in these people, yeah, within normal limits or high is the standard theory there. But when you look at it on labs, you can definitely see some patients will have labs where potassium is low. So it's a tricky thing. There's no solid answer for it per se. I usually go with total body potassium depletion. Just remember that part. Right? Total body potassium depletion. Okay, because that's the main issue with the labs. You're not really gonna see much else notably. The pH is obviously a big thing. Their pH is gonna be very low. It is an acidosis. They're gonna have super high glucose levels because there's no insulin, and then they'll give you some other information about what's happening. Right now, it usually occurs in type 1 diabetics because in type 2 diabetics they usually have enough insulin production of their own to prevent the lipolysis and ketogenesis. All right, now next question. All right, so we did this one. All right. Okay, this is just a memorization thing. It's really not that bad. I'm going to show you how to memorize this. So 65-year-old woman with a 20-year history of osteoarthritis of the hands now has pain radiating down the distal anterior thigh, knee, and medial leg, as well as foot. Bony outgrowth of vertebrae compressing one of the spinal nerve is suspected. Compression of a nerve root in which of the following intervertebral foramina is the most likely cause of her symptoms? So this patient clearly has sciatica because they're telling you the way the pain is radiating, right? Anterior thigh, knee, medial. Oh no, this isn't the sciatica one. No, I'll show you the sciatica one. Actually, the sciatica one goes down the back, right? This is anterior. So now this exact path that is passing, it goes over the knee and medial leg. That's how you are supposed to remember it. So they gave you all the possible answer choices. Let's go look at it in the book for how to memorize that, right? Because there's a really nice memorization tool for this. So this is where they talk about it, right? Our patient is having this first one, right, going over the knee and then the medial leg, right? So that's L3 to L4. The other one, this one is the least tested one, L5, okay? And then this is sciatica, which is behind, right? So you can see the patient turn around, right, going down the back of the leg, and it's lateral, right? So all of these, the answer choices are just going to be L4, L5, or S1 if it's one of these things. And I wrote over here, L4 affects the first toe, which is medial, okay? So L4 affects the first toe, and it goes over your patella, right? So you have to remember patellar, right? Decreased patellar reflex, femoral nerve. You have to remember that, which is also with an F. These are all with Fs. L4, first toe, femoral nerve. L5 affects the fifth toe, which is your lateral one, tiny toe, right? The pinky toe. And that one, it just wraps around your leg like that. It's a pretty weird one, rarely ever tested. S1 is the one that causes sciatica, and that's this pain behind, right, with decreased Achilles reflex, and this is the tibial nerve, okay? So our patient, when they tell you it's anterior, right, anterior thigh, knee, medial leg, and foot, medial, that's your first toe, the big toe, so that's L4. So how do you pick the answer choice here? That's going to be C, L3 to 4. Right? Something over here has caused the issue, L3 to L4. Right, between L3 and L4, you compress the nerve below the root, so you compress the nerve below L3, which is L4, okay? And that's what they're showing you in these images. Really important to understand how that compression occurs, right? Here they're showing you L4, L5 protrusion, right? This is the L4, L5 protrusion. If it protrudes out, it's going to compress the nerve below L4, which is the L5 nerve, okay? So really important, this here, L5S1, this protrusion, you see how the disc is protruding, it's compressing this nerve. Basically what you're looking at is normal nerve path is this, right? This is your normal nerve, right? And that is your L5 nerve, okay? And you see how this L4 came out and is compressing the L5 nerve. Okay, so every disc compresses the nerve below it. Right, very important to remember that. So that was it for this guy. L3 to L4 affects the knee and first toe. L4 to L5 affects the fifth toe, and L5S1 causes sciatica, which is posterior. Okay, so 15-year-old girl is brought to the physician by her mother because of a one-day history of redness and painful skin following sunbathing. She reports that she used sunblock every few hours. She takes no medications, and this is a pretty high-yield topic for NBME. A medication you can take that causes this kind of reaction would be doxycycline. Very important to remember that. They had a question on this in another NBME where they mentioned a girl was taking some antibiotics, and when she went sunbathing or something, she ended up having photosensitivity. Right? But this one, they tell you she's not taking any medications. Physical exam shows severe erythema of the back and extremities, no blisters. Which of the following best describes, right? This is a dermatology question. So she was just sunbathing, and now she ended up sunbathing too much, even with the sunblock. Remember, just because someone says they use sunblock doesn't mean that it was the right amount of SPF, right? It's not enough protection. Maybe they needed a stronger sunblock. Maybe their skin is more sensitive to sun. Here, the answer was just B. It's just a first-degree burn. It's obviously not second or third degree, right? Second or third degree would be really bad. Second degree is superficial, partial thickness, extends into the papillary dermis. You would have blistering. Third degree burn, right? A third degree burn is really bad, right? That's going to go through everything. You might even see bleeding in these people. So that's a whole different thing. And fourth degree extends through the entire thing as well, all the way to bone, possibly, right? So, black skin with the charred eschar, right? And those are that wasn't even an answer choice here. A tricky answer choice here was an allergic reaction to sun, right? An allergic reaction to the sun, but allergic reaction to the sun would have probably presented earlier. It wouldn't happen just because she was sunbathing. You know what I mean? That's definitely one thing. And they didn't really give you enough information to pick something allergic, in this question base. They didn't tell you. I think even an allergic reaction might even have blisters because allergic reactions are from inside. So you're ripping through as you're reacting, right? Allergic reaction comes from inside. She doesn't have an internal thing happening. It's just a response to burning too much. That's it. Very straightforward question. 48-year-old man begins furosemide therapy for pedal edema associated with biventricular failure and hypertension. 5 days later, the edema is not fully resolved, and his serum potassium concentration has decreased from 4.2 to 3. A drug with which of the following actions should be added to this patient's medication regimen? Okay, so we just finished renal in my full FA playlist, and basically the concept was that almost all renal pharmacology reduces potassium levels, right? And what's happening with this patient is that we gave her furosemide, which is a huge, very high-yield loop diuretic. You lose a lot of potassium there. You also lose calcium. It's ototoxic, right? There's a lot of things there. Since this patient already lost potassium because of furosemide, we cannot give this patient another diuretic that causes more potassium loss. Right? That's what this question is about. Patients who are not being treated well enough because of any other diuretic, the next thing you had has to be a potassium-sparing diuretic, so something like spironolactone. So you look at all your answer choices, and B decreases the luminal permeability to sodium in the collecting duct is exactly what a potassium-sparing diuretic would do. Right, so now a potassium-sparing diuretic can be added, and potassium-sparing diuretics are aldosterone antagonists. Right, aldosterone antagonists, and aldosterone antagonists decrease sodium permeability, right? Because aldosterone's job is to save sodium. Aldosterone antagonists will not save sodium. And that B was the only other answer choice. Blocking basolateral potassium channels would lose potassium. Increasing the delivery of sodium potassium to the collecting duct would also lose potassium because once you go to the collecting duct, you pee it out. Increasing the negative charge of the luminal tubule was just irrelevant. And stimulating the sodium potassium ATPase would also lose potassium. Okay, so these are all just not going to really work. Okay, so if we go to 663 real quick in renal form, we can see all the diuretics. We talked about this recently in our new videos, and you can see how aldosterone antagonists here, right, would be what we would be using, something like spironolactone, right? And as an aldosterone antagonist, your job is to prevent sodium reabsorption, right? So they tell you here, either it's going to be a competitive aldosterone antagonist, or the other guys, tramtrine or amiloride, they block sodium channels at the same part of the tubule, right here. All in all, the job they both do is the same thing, stop reabsorbing sodium. And if you lose sodium in your urine, you lose edema. You lose water in your urine too. So it works. Okay. 10-month-old girl is brought to the emergency department because she is pale and unresponsive. Her mother has given her 3 adult doses of loperamide, a medication NBME likes talking about, over the past 6 hours for diarrhea. Her pulse is 120 per minute. Respirations are 10 per minute. Examination shows marked abdominal distension. If medication is required, which of the following is the most appropriate therapy? So if you don't remember what loperamide is, then you're a little screwed. But generally speaking, loperamide is a very good and very high yield medication because it's also an opioid. All right, the medication is discussed in GIT and is used for diarrhea. It can cause constipation. It is an opioid that slows gut motility because all opioids slow gut motility. And remember that no matter how much tolerance you might have to opioids, you always develop constipation anytime you take opioids, right? There's no tolerance to that. There's also no tolerance to the constriction of the eyes. This one, loperamide, has poor CNS penetration, so there's rarely ever going to be ever a question where a patient is addicted to opioids because they were taking loperamide. Naloxone is used for opioid overdose, as is the case here. And you know she has some kind of overdose of medication that's causing respiratory depression, right? Respirations are 10 per minute. So once you see the respirations are 10 per minute, that should have been a big, point to you. Even if you didn't know what loperamide was, you look at all your answer choices and you should know what each one of these are used for. And then you see naloxone and you add together the fact that naloxone and respiratory depression makes sense. You would give naloxone to any random patient that pops up in your clinic and they have respiratory depression. Just give them the naloxone and then later find out maybe they overdose on opioids. Okay, you don't wait to find out what's wrong first. You just see the respiratory depression, you give naloxone, move on with life. Okay, and that's basically what happened with this 10-month-old girl. The mother gave her 3 adult doses, right, which was too much, and the mother fucked up. Mother almost killed her baby. Okay, this was cool. So this is another thing NBME really likes. They like giving you neurology questions that often utilize images that might be a little intimidating because they look a little too real, right? Too real because this is a real one as opposed to like a cartoon one like this one or that one, right? So a 28-year-old woman is brought to the physician because of a 3-week history of double vision. 1 year ago, she had an episode of blurry vision in her left eye that gradually improved during the next 2 months without treatment. And as soon as they give you that, you kind of have an idea that she most likely has multiple sclerosis. Right? Neurologic exam shows that the right eye does not adduct past the midline on horizontal gaze when looking to the left. Okay, so the right eye adduction means adding them together, so looking towards your nose. So when she's doing horizontal gaze towards the left, her right eye doesn't look to the left, right? That's adduction. And when they describe that to you, the horizontal gaze issue, that's INO, internuclear ophthalmoplegia, which is also pretty pathognomonic for multiple sclerosis. When convergence is tested, the right eye is able to adduct just fine, right? Convergence meaning both eyes are looking towards the nose, then it works. Rightward horizontal gaze is also normal, which means the left eye is doing okay. This patient most likely has a lesion involving which of the following label structures. So you know INO is due to the MLF lesion, right? Medial longitudinal fasciculus. Since you know it's called the medial longitudinal fasciculus, whichever answer choice you pick better be medial, right? And there's only 2 answer choices on this that are medial, C or D, okay? So that much you should be able to do as a medical student who's been studying, right? You should be able to figure out what's wrong with this patient, get the diagnosis, and then know the physiology or the pathophysiology of the problem. Because just by knowing that much, we were able to come down to a 50-50 chance of picking the right answer. Now you apply the other knowledge you have in the nervous system where things are often backwards, right? So since she has right eye not adducting, right, it must be an issue with the left side, right? And that logic only applies to one thing though. Keep in mind, things are only going to be switching sides if you're going from the brain to the body, right? But if you're going from the brain and staying in the brain, it stays on the same side. So what I just said, right, that if it's the right eye, remember we're talking about the eye here, so it's not going to switch sides. But if you were talking about one of your tracts, like the spinal thalamic tract or corticospinal tract, those go from the brain to the body. Those guys switch, right? So for staying in the brain, it'll stay on the same side. So if the right eye does not adduct, you pick the right answer choice. So that would just be, and they labeled it for you nicely here. They told you this is the left, so the answer must be C, and that's it, right? And that was the correct answer, C. When I was doing, in case you haven't joined previous NBME explanations, when I do NBME explanation videos, I usually take the NBME myself too as I'm writing the explanation. So like when I read this question, I knew what was happening from the question, but this image did intimidate me because it had been a while since I looked at it. But I knew that what I'm looking for is called the medial longitudinal fasciculus, which must be medial. And then I knew that the right eye is not working, so it must be the right one. And I just chose C. But I wasn't 100% confident when I picked C, right? And then I checked and it was C, so that just worked out, okay? So very important to be able to do that kind of like, deducing the right answer kind of stuff. Keep in mind, my neurology videos are also actually really good. I did a great job breaking down all the tracks, telling you how to memorize them, telling you how the pathologies would present, understanding the tracks and the different levels at which they decussate, what those decussations mean, stuff like that. So very important to be able to figure that out. And then I've added some extra images for anyone that goes ahead and purchases the explanations. It's really important to know what all the other stuff are. Now, you don't need to know all of them, but it's nice to have a basic idea, just looking at it one time. So that if it ever shows up, maybe it'll ring a bell for you. But you don't need to know all of it. You definitely don't need to know all of it. Just know the basics. Know the very, very basic stuff. You definitely need to know multiple sclerosis and INO. Okay, very important stuff. So let's take a look at INO real quick. Okay, so right here, right, this is basically what was happening to our patient. Our patient had right INO because when the patient looked to the left, the right eye was not adducting, right? And remember that the disease is named based off of the eye that's pathological. So this is called right INO because the right eye is not doing it, right? It's not looking towards the left, okay? Whichever eye does not adduct, that's the one that you have an issue with. So our patient had an issue with the MLF, and you have to also be, from the neurology videos, you have to be able to understand what level you're at when an image is given. Are you in the pons? Are you in the medulla? Stuff like that. What did they tell you? They gave you the brain stem. So they didn't even tell you if it's like the pons or medulla, right? But you have to be able to figure out what's being given to you. And these are images of your actual medulla as well. So I put it here too. Right, it's very important to be able to see that. You see how you have the abducens nucleus right here in the pons, and then it goes to the medulla, and it's on the right side now. Your right MLF comes from the left pons. Okay, very important to be able to catch that. So this kind of stuff can be often very confusing for people, but generally speaking, just pick the same side stuff. Pick the same side stuff when everything is in the brain, when it's not a tract that's leaving the brain and going to the body. Okay. And you do need to know where each nucleus is, right, by the rules of the 4, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, right? They're all in different parts of the brain. You need to know where they all are. I think that's about it. It's not so bad. It's not a very difficult topic. It's definitely one of the topics you do need to spend some time on, though. Okay. So yeah, that's INO right there. This one, 9-year-old boy is brought to the physician by his mother because of a 1-year history of cough productive of mucoid sputum, wheezing, and shortness of breath with exertion. He has a history of recurrent upper respiratory tract and sinus infections since birth. He's at the 25th percentile for height and weight. Mother says that his younger sibling is beginning to develop similar symptoms, all of which now really points you at cystic fibrosis. Physical exam shows mild clubbing, which also happens in CF. And then they confirm cystic fibrosis by telling you that the lab studies show markedly high sweat chloride and sodium, a defect of which of the following in the patient's bronchial epithelium is most likely causing these symptoms. Right? And you look at all your answer choices, and this is basically asking you the pathophysiology of cystic fibrosis, and it's due to protein structure. Right? You don't make a good channel protein. It's messed up structure. The misfolded protein ends up being retained in the RER. Okay, It's not a membrane receptor, which was the other answer choice a lot of people picked. Okay, it's not a receptor. It's a channel. So let's take a look at it real quick, because this is one of the top high yield topics, cystic fibrosis, right? So they tell you defect in the CFTR chromosome, you encode you're supposed to encode a really nice channel, right? But there's a mutation and you get a misfolded protein, okay? And you have to remember what it does. It has different jobs in the sweat duct and different jobs in the airway. In sweat ducts, the CFTR reabsorbs chloride. Without it, you're unable to reabsorb chloride, so sodium stays with the chloride. In airways, you see it's supposed to secrete chloride, okay, into the mucus, so that the mucus is very nice and hydrated, right? But now you're unable to. So again, sodium stays with the chloride, so sodium comes back in. And since sodium came in, water always follows sodium. Right? So water also came in. You get very dehydrated mucus, which is very solid mucus. And solid mucus causes mucus plugging. Okay? And mucus plugging occurs everywhere. Pancreas, biliary duct, salivary glands, everywhere. And patients can present with pancreatitis and all kinds of other problems. Right? Okay. This is 25-year-old woman is admitted to the hospital because of septic shock. She underwent splenectomy 6 months ago after she sustained traumatic injury during a motor vehicle collision. And just for your knowledge, as far as NBME is concerned, any patient that underwent splenectomy did not get vaccinated, which is bullshit, right? Because in real life, when you get splenectomy, you get immunized for all the encapsulated bacteria or bugs and stuff like that. But on NBME, all these patients who undergo splenectomy or autosplenectomy due to sickle cell, whatever the case might be, we never immunize them because we're really bad doctors or something like that. Right? So she underwent a splenectomy because of a motor vehicle accident, which is very common. And then they didn't immunize her. Her temperature is super high, blood pressure is very low, coarse tubular breath sounds are heard bilaterally, and egophony is heard at the right base. A chest X, so that means she has consolidation at the right base. A chest X-ray shows bilateral pulmonary opacities, dense consolidation at the base of the right lung, which they're reiterating to you, and a possible right-sided effusion, which means that on the chest X-ray they probably can't see the diaphragm angle in the bottom right corner. Which of the following is the most likely causal organism? And then you look at all your answer choices. So my explanation: for some dumb reason, this woman underwent a splenectomy but was not immunized. Never assume the correct procedure for this, which correct procedure involves immunization. Splenectomy patients are vulnerable against encapsulated organisms, which commonly include strep pneumo, Neisseria, H. influenza. Although Pseudomonas klebsiella are also encapsulated, and they are answer choices here, Pseudomonas aeruginosa, Klebsiella pneumoniae, strep pneumo is more common for pneumonia in a 25-year-old female without other comorbidities. Klebsiella pneumonia would be in a hospitalized patient, right, who's taking a lot of antibiotics, and Klebsiella is pretty resistant to most antibiotics. Pseudomonas aeruginosa would present with many other things. It's usually also related to air conditioners or swimming pools and stuff like that, and has many other problems other than just the lung thing. Okay, she only has issues directly related to and within the lung, nothing else. Okay. So that was it. Bacillus anthracis doesn't really fit the scenario at all. Actinomyces israeli is a acid-fast guy, right? And he's this is the one you study with nocardia. Both of them go together. And Actinomyces israeli does not cause this kind of stuff, right? So not so bad. 54-year-old man has an aneurysm in the distal portion of his abdominal aorta. And then they toss a math question at you, which was really interesting because you didn't really need to know the equation to solve this. The estimated cross-sectional area, so let's take a look at what's happening, right? Because you got to be able to deduce things. They tell you that the cross-sectional area of the lumen, right, is 2 centimeters squared. Okay, so this cross-sectional area is 2 centimeters squared. And the mean velocity of blood flow through the aneurysm, right, is 20 centimeters per second. Okay. Which of the following best represents the flow rate in liters per minute through the aneurysm? All right, so we have 2 centimeters, 20 centimeters per second. This is going through here, right? They want to know the flow rate. Right, so how would you do that? Now, if you don't know the equation, right? If you don't know the equation, then there's really not much to do. You're just going to panic and pretty much give up. But flow rate, just looking at this, it looks like if 20 centimeters per second is passing and this is 2 centimeters, you probably just go ahead and multiply them, right? Because you're not going to divide them. It doesn't make any sense to divide them. If you do multiply these two things, you get 40, right? You get 40 centimeters squared per second, right? That's just what you get from multiplying those two guys together. Now, wait, what was aneurysm is 2, and the aneurysm itself was also 2 centimeters squared. Okay, but that information doesn't really help. The aneurysm, wait, what did I just do? Hold on one second. Estimated cross-section of the aneurysm. Yeah, so this was 2 centimeters squared. Oh, sorry. So this is going to be 2 centimeters cubed now, which is a lot better because we need something to become volume, right? And for volume, you need centimeters cubed. And that's a mathematical thing you need to know. Volume is always going to be centimeters cubed or something cubed, right? Because you need a cube to fill it with water, right? So that's one way to kind of memorize that concept if you don't know it. Excuse me. For volume, you need centimeters or whatever unit it is cubed. Okay, so 2 centimeters squared was this area. 20 centimeters per second was the flow that they gave you, the velocity of the blood flow. You multiply that, you get 40 centimeters cubed per second. And now you're kind of stuck because now you got to remember how to convert this into liters per minute. Well, to convert things to minute, that's not so hard, right? Because now you just multiply this with 60 seconds per minute, right? So the seconds are going to cancel out, and you're going to multiply those two numbers, and then you'll get another number. But now you have to convert that new number you got into liters. And liters, you have to remember that 1 liter is equal to 1,000 centimeters cubed. And this is why we needed a centimeters cubed. So just knowing units and how to work with numbers really, really helps, because once you saw the 2 centimeters squared and 20 centimeters, it was very obvious you need to multiply those two to get a centimeters cubed. From there, it was just conversion. Okay? So very important to be able to do that kind of stuff. It was not a hard question at all. But most students who I showed this question to were very confused, mainly because they didn't anymore recall the equation, right, which is the flow rate as velocity times cross-sectional area. But that was the easiest part. That was this, right? 2 centimeters squared times 20. That was the easiest part. The converting was the slightly harder part, and you have to be comfortable with converting. It's not something you can be struggling with. Got to be able to do the converting, all right? If you're having trouble understanding how to convert things, just look up basic stuff. I mean, the other guy who I really respect for very good free videos online is Khan, right? He has very good tutorials, and all of his videos you can see he'll show you how to do like conversions very, very easily. But generally speaking, you want to make sure you know at least this one for sure, right? Liters and minutes, converting time and converting liters, kilograms, those kinds of basic things. Those are stuff that comes up pretty often. You want to be able to do it. And here you would do that, you would get the answer 2.4. 2.4 liters per minute is passing through the aneurysm area. Okay, so very important kind of stuff. This is stuff you'll probably never do as a doctor, but you do need to be able to do it for step 1 in NBME. Okay, this was a good question too. So this is another topic that NBME does talk about, and it's cardiovascular related. So 66-year-old man develops worsening shortness of breath and swelling of the legs. He had a myocardial infarction 6 months ago. Pulse is 120 per minute, and blood pressure is 135/82. Examination shows distended jugular veins, bilateral crackles, and pitting edema in the lower extremities. Serum sodium concentration is 129 milliequivalents per liter, so it's low. Which of the following is most likely responsible for the hyponatremia in this patient? So, if you need to figure out what's wrong, first thing first, you want to figure out what causes hyponatremia, right? And this is a UWorld chart giving you the pathogenesis of CHF, and you do need to know everything that happens in CHF, as well as the connection of CHF with the RAAS, right, with the renin-angiotensin-aldosterone system, which tries to fix things, right? And that's here too. right? You get activation of the renin-angiotensin-aldosterone system. So aldosterone is making plays, right? Aldosterone is making plays. But this patient has hyponatremia. Aldosterone's job is to conserve um, sodium. So this is definitely not related to aldosterone. Then you think of the other players in heart failure and think of one that really causes sodium loss. And the one that should immediately come to your mind should be atrial natriuretic peptide. Natriuretic peptide makes you lose sodium, right? And its job is to kind of make you lose that edema. That's why you have atrial natriuretic peptide. Let's take a look at all our answer choices now. So A, dilution of serum sodium due to ADH secretion. I mean, this is something that makes some sense, and there is ADH activity as well, but it doesn't seem like the best answer choice because that's not what we're looking for. B, increased urinary sodium excretion due to renal tubular dysfunction. You would not have renal tubular dysfunction. There's no reason for that. They didn't give us the fact that this patient has renal disease, nor did they tell you creatinine or anything like that, so B is wrong. C, increased urinary sodium excretion due to secretion of aldosterone. False. Aldosterone conserves sodium. You would not have urinary excretion, so that's not right. Increased urinary sodium excretion due to secretion of ANP. Now this seems like the answer we were looking for, right? And just follow along. It looks like the answer you were looking for, so you keep that there. And E, restriction of dietary sodium intake. That doesn't make sense either. Had this patient been restricting his dietary sodium intake, that would actually be a pretty good thing. So now you're between A and D, and you want to be clever, right? Because remember, NBME is trying to fuck you up. Keep in mind that although patients do release atrial natriuretic peptide, you can't really see it on this table. It's not here, right? It's not here. And this is a table you want to have good visual memory for. Almost everyone picked D as an answer choice. Okay, and I'll be honest, I did too, right? So what I was doing with you right now was the mind map that I had, right? But what I didn't stop and think about, because I'm not really taking it as a serious test, is the fact that it's not on this. It's not really discussed anywhere. A and P is only discussed in one part of first aid, and you always want to remember where things are listed on first aid because it kind of tells you what else is connected to it. It's just listed on that one place where they talk about A and P, and it's not in relation to anything else. Keep in mind that if A and P was actually good enough, right? If A and P is actually good enough, then you wouldn't need anything. Your body would take care of itself. So let's take a look at what I wrote here. CHF patients often have signs of excess ADH secretion, which is critical. ANP and BNP do not have much effect and are practically useless. They are significant in hyperaldosteronism for the aldosterone escape mechanism, which keeps sodium levels normal in hyperaldosteronism. I think a lot of people might, so this was a note I found online, I think a lot of people might have overemphasized how important ANP and BNP really are. Yes, it is important to know these peptides get secreted by the atrial and ventricular myocardium during heart failure. However, their overall effectiveness in treating heart failure is pretty much zero. A preceptor told me that if ANP and BNP were so useful in natriuresis, then why do we give diuretics? It is because RAS overpowers this system, hence causing negative effects and the endless loop of heart failure. Right? This is why we have to give ACE inhibitors. Knowing that ANP gets neutralized by the RAS system, we can shift our focus back to heart failure in this patient, where cardiac output is decreased, leading to ADH secretion and finally dilutional hyponatremia. So this was actually a really awesome question, right? I got it wrong. There was something I didn't know very well. Khan Academy. Khan Academy is a very big guy. This guy started up initially just teaching from home like I do with, he used to make videos for his nieces or something. And then he was just very good, so he became very famous. And he has now a big-ass company with many people and teaches everything, not just one topic, everything. Anything you could think of. So if you need help learning how to convert units, he definitely has very good videos on converting units too. Okay, so here the answer was A. Right, so keep in mind that do not fall for what I did. When I saw low sodium, I started thinking of atrial natriuretic peptide, which I know is released in heart failure. However, ANP's activity is over overtaken by RAS. RAS is much more powerful than ANP is. So although ANP causes you to lose sodium, aldosterone from the RAS system conserves the sodium, so you don't really lose much sodium at all. So this patient's hyponatremia was not due to ANP. This patient's hyponatremia was due to the ADH, right? Very high extracellular volume, dilution of serum sodium due to ADH. Okay, and this sodium level wasn't that low either. Like 135 to 145 is normal. 129 is probably due to the dilution. Remember, this is milliequivalents per liter, right? That was the other thing I want to point out to you guys. They didn't give you total sodium. They gave you sodium concentration. Concentration means how much is in a certain area, right? How much is in this area, not how much is in the total body of the patient. So the fact that they were talking about sodium concentration was also a big hint that the answer is A. You're diluting your sodium. The concentration of sodium is lower, not your total amount of sodium. So this patient's labs might actually have normal sodium levels, 135, 140, something like that. But the concentration is diluted, right? So very important to understand the difference between that terminology. Alright, so now next one, this was just something NBME loves doing. Toss a gross image at you, figure out what's wrong. Now, good thing is that they actually gave you a lot in the question too, but this was just a very easy question to begin with. You know, first of all, as soon as you see this gross image, that you should be able to figure out this is the kidney, and it looks like there were a bunch of cysts in here, right? Many cysts. So this is polycystic renal disorder. But let's read the question, and when you read it, you figure out it was that, right? A 30-year-old man, constant physician, 2-day history of blood in his urine, dull flank pain, voiding large amounts of urine. Patient states that his father died of an unknown kidney disease as well, because ADPKD is autosomal dominant polycystic kidney disease. His blood pressure is high. Physical exam shows bilateral renal masses, right? Lab studies show proteinuria and gross hematuria. CT scan exam gives you the diagnosis of cystic masses, ADPKD. A right nephrectomy is done. Surgical specimen is shown. Underlying defect is most likely with what? Polycystin. Right? Polycystin, very nicely named protein because it goes with what the problem is. Now, ADPKD is polycystin. ARPKD is fibrocystin or polyductin, okay, which are other proteins that work very similar to polycystin. Also need to remember the chromosomes that are involved, okay? So remember that ADPKD has chromosomes, I believe it was 4 and 16. Let's take a look at that. 592. 592. And 16 was the more common one. Did I write the wrong? Oh, wait, not 592. That's page 592. 592, the actual first date. Okay, right, 592. So that would be, for me, 659. Let me write that in real quick. Okay, so, yeah, 2 kidneys, 2 squared is 4, and 4 squared is 16, right? So chromosomes 4, right? Chromosomes 4 and 16, was that it? Yeah, PKD1 on chromosome 16 and PKD2 on chromosome 4. Okay, so 2 squared is 4, 4 squared is 16, and 16, the bigger number, is more common. 85% of cases are chromosome 16. In case you get a stupid statistical question on any of that, right? What they didn't show you in our gross image was the actual cysts. So the gross image we have is missing these cysts. So that's why you see those empty areas like that. That's where the cysts were. Okay, right. It's a pretty good picture. I'm happy with the picture they picked, and they gave you everything in the question as well. Everything was given in this question actually, which is pretty rare of NBME. NBME does not tend to give you much information. This is a very high-yield topic. UWorld has questions on this stuff too, which I put them here. So, a 60-year-old woman comes to a physician because of a 2-month history of shortness of breath and cough, and a 2-week history of progressive swelling of her face. The cough is productive of approximately 1/4 cup of mildly blood-tinged white to yellow sputum daily. She has had a 5-pound weight loss over the past 4 months, 15-year history of hypertension treated with enalapril, smoked 1 pack of cigarettes daily for 45 years, pulse is 90 and regular, respirations are okay, blood pressure is a little high. Physical exam shows edema of the face and neck and jugular venous distension. And jugular venous distension doesn't just occur, right? It doesn't just occur by itself. JVD You usually see JVD with heart failure, mainly right heart failure, because if the right heart is not pumping, there aren't really many valves there, so blood backs up and goes up your JVD. Right? It goes up your JV, causing the distension. Breath sounds are mildly decreased throughout all lung fields. There's no cardiac murmurs. Serum sodium concentration is 125, which of the following is the most likely underlying cause of this patient's facial edema. So again, serum sodium concentration, which means dilution, right? Sodium concentration, not serum sodium. She has 125 sodium every liter, right? So that's concentration being diluted. So now, what's the cause of her facial edema? And you look at your answer choices and you see lung cancer as an answer and you pick it because she clearly has lung cancer, right? From the whole story that they're giving you in this clinical drawing. And on top of that, there are different kinds of things that can come from different lung cancers, and most likely one of hers, her lung cancer is releasing a lot of ADH, right? And all that ADH is causing her to have too much water, which is why she has edema, right? And that edema is causing a dilutional effect on her serum sodium. And that's exactly what's happening in this question too. Okay, so let me just put that in. Most likely her lung cancer is releasing ADH, causing a dilution effect on sodium concentration and causing edema. And that's basically it. It wasn't any of these other answer choices. Definitely not angioedema. She's been taking enalapril for a long as time. If the enalapril was going to be a problem, it would have happened in the first few months. Hyperthyroidism is just weird. Hyponatremia and hypoparathyroidism just don't fit. Hyponatremia does not cause edema. Okay, the other way around. Hypernatremia can cause edema. Right, so this is the picture of what's wrong with her, right? So she has something like a Pancoast tumor, which is compressing the vena cava and causing venous distension, JVD. That's what I was saying. So JVD doesn't just occur by itself. It has to be right heart failure or something's compressing the blood from flowing correctly. Okay. These were two other Euro questions where they had two different answers: superior sulcus tumor or a mediastinal mass, right? Which was the correct answer as opposed to superior sulcus tumor. But the main point was to figure out where the dilations are. Here you can see that in this diagram, right, with this tumor up here, the dilations are only on the right side, right, the right arm and the right neck. Okay, if it's bilaterally and on both sides like that, that's different. So 762 in respiratory really goes. That's the last thing in respiratory. They talk to you about a Pancoast tumor and superior vena cava syndrome and all kinds of other stuff, right? And it's really important to be able to figure out, like, are you going to see the blanching bilaterally or on one side? Okay, if it's both sides, that's superior vena cava syndrome. That's the mediastinal mass and so on. So definitely want to make sure you understand the difference between that. Okay, you see there's a clot here in superior vena cava syndrome. This is 57. So 57-year-old woman comes to the physician because of episodes of burning, shock-like pain on the left side of her face in the past 4 months. Several episodes each day, usually caused by chewing, which gives away the diagnosis, right? Trigeminal neuralgia. The pain lasts 5 to 10 seconds, which is typical. Neurologic exam shows no abnormalities. What is the most likely diagnosis? Super easy question, trigeminal neuralgia. Right? If only every question was this easy. So this was pretty straightforward. Nothing insane happening. This is diabetes insipidus, also a high yield in NBME. 42-year-old man comes to the physician because of a 1-month history of fatigue, excessive thirst, and frequent urination with large volume. He's 5 feet 10 and weighs 135. BMI is okay. Pulse is 96. Blood pressure is low. Physical exam shows dehydration. Right, so we don't necessarily yet know if it's DM or DI, but then they give you the lab. Fasting lab studies show glucose is normal, so it's probably not diabetes mellitus. ADH is high. Osmolality is high, and urine osmolality is low. Okay, so this is all diabetes insipidus, right? ADH is vasopressin. It's also antidiuretic. You're not supposed to be peeing, right? But then urine osmolality is low, which means that the patient is peeing. Okay, how do you know that? Remember, ADH is antidiuretic. There's going to be no water in the urine. So if your urine osmolality is decreased, that means that the sodium concentration in your urine is decreased. That means you have a lot of water in your urine. So ADH is being released but not really doing its job. Chances are this patient most likely has nephrogenic DI. In addition to a low sodium diet, which of the following drugs is the most appropriate treatment for this patient? And the answer here was hydrochlorothiazide. Hydrochlorothiazide is the drug of choice for nephrogenic diabetes insipidus because it paradoxically causes an increase in blood pressure by increasing sodium absorption and thus water absorption. Desmopressin is incorrect, which was the other answer choice, the trick answer, because upon fasting, which is fluid restriction, ADH is increased, meaning ADH is being released centrally but is not working at the V2 receptors of the renal collecting duct. Desmopressin is for DI, central DI. Okay, amiloride is used for lithium-induced nephrogenic DI, which was not an answer choice here. Okay, so fasting labs are what helped us figure out if the patient has diabetes mellitus or insipidus, and whether it's central or nephrogenic DI. Very important to be able to diagnose all of that. And this was clearly nephrogenic DI because the patient is releasing ADH, but ADH is not having any effect on the urine. Okay, urine osmolality should be increased when you have ADH secretion. Okay, because you are not going to be putting water in the urine, so that means most of your urine is just going to be electrolytes. Electrolytes increase osmolality. Urine osmolality is like urine sodium concentration. Osmolality and sodium concentration are the same exact thing. As far as the test is concerned, you can talk about it like that. 59. So 1-year-old boy is found to have an impairment of the respiratory burst of phagocytes. He has a family history of immunodeficiency. Patient is at greatest risk for infection caused by which of the following organisms? So respiratory burst is related to the NADPH stuff, right? And this patient has NADPH deficiency. That's known as chronic granulomatous disease, which is treated with interferon gamma. Even though patients with CGD cannot make superoxide, they can use it from the bacteria and convert it to bleach and kill the bacteria. But bacteria that have catalase enzymes neutralize their own superoxide. So what's happening here is basically us humans, even if we don't have NADPH, right? If we don't have NADPH, we're still able to use the bacteria superoxide, and make it into HClO and kill it. But if the bacteria has catalase, they're going to use their own superoxide, and we won't be able to use it. So now we cannot kill catalase-positive bacteria if we have NADPH deficiency. Right? And that's what this image is kind of helping you understand. So now you just have to pick an answer choice that was catalase positive, and that's D, Staph aureus. Right? There is a cat in the Staph aureus image, which is the first image in Sketchy Micro. And the first bacteria, and arguably the most high yield bacteria of first aid. Okay, so last question for this video. We're into block 2, 10th question of block 2. A 13-year-old girl is brought to the physician by her mother for a routine well child exam. Neither the child nor the mother has any particular health concerns. The patient is doing well in school and participates in soccer and lacrosse in a local recreation league. The physician wants to ask the patient about sexuality and sexual activity. Which of the following actions by the physician is most appropriate? Okay, so very, very important topic, especially for INGs, especially for any doctor coming from countries like India, Pakistan, Bangladesh, these countries. Many Eastern countries don't believe in, discussing sexual topics with the patient, a 13-year-old girl, without the parent there, right? And many Eastern countries also believe in sharing openly any sexual conversations done with their child with the parents. That's wrong in America, and it's wrong in general. You can't do that because then you take away the comfort that this child would have in discussing such topics with the physician. And if your child doesn't discuss things with you, they're going to go do more fucked up shit and they can die. And not die, but they're going to go through something really bad. So the 13-year-old patient might feel uncomfortable discussing such topics with her mother there. That is a simple enough reason to ask the mother to leave. This could also be a sign of potential sexual abuse, which might be why this 13-year-old girl is aware of sexual activity. But it could also be something harmless from something she learned or saw online. Either way, comfort is key, right? Very important. In first aid, they talk to you about it. If a younger child comes up to you and knows about different sexual positions or orgasms or the sounds of sex or anything like that, it could be a sign that that young child is being sexually abused. Otherwise, a young child like that wouldn't really know about those kinds of things. The only other way would be maybe someone in school showed them a porn video or something. So that's the other thing. All these answer choices were here to bait different kinds of people from different kinds of Western hospitals. Eastern hospitals, right? So ask the mother to leave the room before asking the patient any questions. That's the correct answer. Ask the patient to leave the room and then ask the mother about her daughter, right? Why would you ask the patient to leave the room? This is already wrong as soon as you see this. Ask the patient to leave the room? That's wrong. Ask the questions with both the mother and patient present. That's what most Eastern hospitals and doctors in the East generally do. And I've seen doctors coming from the East here and doing it here too. So it's not far-fetched. It does happen. Give the patient a questionnaire that she can fill out at home. Completely wrong. Giving the questionnaire could be correct, but doing it at home, now you don't even know if the patient did it, the mother did it, who else saw it. Tell the patient that some sensitive questions are next and that only she can ask them, and only she can ask her mother to leave the room. That doesn't make any sense, right? Why would you ask the patient to ask her to tell your mom to leave the room? That's stupid. It's your clinic. You're the boss. So very important, very nice question, very realistic question. You gotta be able to handle stuff like this. Do not ask sexual related questions to a young adult, or not even an adult, a young patient, very adolescent, young patient. Do not ask them sexual questions with the parent there. They're never going to tell you the truth, right? They're worried what their parents are going to judge them for. And on top of that, never share any of that information with the parent. Your child is pregnant, your child has an STI, any of these things you don't tell the parent. It's confidentiality. The patient is your customer, and you're the boss of this clinic. You tell people to leave. If the mother said, I'm not going to leave the room, you don't ask the questions, right? And then if you really suspect child abuse or sexual abuse of the child, you call the authorities, let them know, okay? So that's how you deal with these kinds of things. I'm going to stop here up to question 60, and then I'll continue to question number 61, continuing on block 2 in the next video. Thank you very much for joining. Make sure you subscribe so you can get notifications, and also make sure you turn on notifications, because in my analytics table I can see a lot of people have subscribed but they haven't turned on notifications, so they won't really know if I go live. And it's nice to join the live sessions because you can ask questions all you want. And yeah, thank you very much. I'll see you guys again very soon.